Welcome, everyone, to yet another edition of Three Plastic Surgeons and a Fourth. As always, I am Sam Jejurikar in Dallas, and I'm joined by Dr. Sam Rhee, who can be found on Instagram at Bergen Cosmetic, who's in Paramus, New Jersey. Dr. Salvatore Pacella in La Jolla, California, who can be found on Instagram at San Diego Plastic Surgeon. And Dr. Lawrence Tong, who is joining us today, despite being a little bit under the weather, who's in Toronto, Canada, and whose Instagram handle is at Yorkville Plastic Surgeon or Surgery. Surgery. I was so close. I always goof that up. Today, I think we're going to be talking about a topic that our viewers will find interesting because there's a lot of controversy in the plastic surgery world about different types of facelifts. And there's lots of nuances to facelifts, types of incisions, whatnot. But today we're going to focus on different planes or different depths of facelifting technique. And specifically, we're going to talk about traditional facelifts, more superficial facelifts, and something known as the deep plane. So before we get into the meat of it, Dr. Pacella, will you read a disclaimer, please?
This show is not a substitute for professional medical advice, diagnosis, or treatment. The show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something on the show.
So I think what's prompting us to talk about this topic today is, controversies within plastic surgery about the various depth of facelifting technique have existed for at least 30 or 40 years. And the deep plane facelift is not a new technique. It was a technique that, was popularized by Sam Hamra, who was a Dallas plastic surgeon in the 80s and 90s. But it's made a resurgence. And a lot of patients are coming in to talk to all of us wanting to know more about this. So question I have for you guys is, do you guys do the same facelift procedure on everyone? Do you guys do deep plane facelifts? Just sort of curious about what your approach is to facelifting patients.
Yeah. So just one thing you said there, Sam, the deep plane facelift is not a new technique, but it is a new hashtag. Okay. And so that's what's kind of making the resurgence is a popularity in that kind of hashtag. And that's kind of fueled by some media stuff, some literature stuff. And it's kind of fun to watch because it is providing, in my opinion, a better value for patients and a long-standing result. So to answer your question, I would say that, anatomically in the human body, there is no other area that is as variable as the human face. Okay. Even if, as I'm sitting here looking at the, our faces on this podcast, some of us have big parotid glands, some of us have big SMAS or muscular layers. Others have thinner skin. Look at Larry. He's pretty slender and thin. His parotid gland is going to be very small. Samir, you have mesenteric hypertrophy, so your carotids probably will be massive if I ever did a facelift on you. So the anatomy is so variable. And so, to me, every single time I do a facelift, I have a new approach. And it's not necessarily a new approach, but a tailored approach, I should say. And sometimes the approach is modified based on what I see anatomically. So in some patients that have not had a facelift before, it's fairly easy to do a straightforward deep plane facelift. In some patients who have potentially had surgery before, I may do more of a composite or a deep plane, elevating a small amount of a strip of skin. So it is exceptionally variable. And I think that's a good thing because it tailors the procedure exactly to what the patient needs.
So specifically, Pacella, it sounds like you're advocating an individualized approach for patients. But what is a deep plane facelift? You're talking about it, but for people that don't even know but have heard this term, what is it?
Larry, you want to?
Sure. So first of all, we'll go even more basic than that. What most people describe as a facelift is a procedure that is going to rejuvenate the neck and the face. So it's a combination of doing something like this for the face and doing something like this for the neck. That's commonly what is accepted as a facelift. So when facelifts were first performed, when they were first done as a surgical procedure, a lot of times they were just done as what's called a skin-only facelift, which is a procedure where they just lifted the skin, pulled the skin back, removed a little bit of skin. They did that for the face and the neck, and that was a skin-only facelift. And then as time evolved, surgeons started to notice that they might get better results if they were doing things to the deeper layers of the face. So under the skin is the next layer deeper is sort of the muscle layer. And surgeons started manipulating that. And specifically, there's a layer on top of the muscle called the SMAS layer. And that is a layer that surgeons also started to manipulate. And so it evolved to a procedure where they were tightening the SMAS. And then a newer technique came out where they actually went even deeper than that. They went under the SMAS and they started lifting the SMAS and not necessarily lifting as much of the skin. So the skin was attached to the SMAS and they pulled that deep. So the deep plane facelift is basically a procedure where the plane of dissection is underneath the SMAS, and it's noteworthy that it's a sort of a more challenging procedure because that's where the nerves are, the nerves that move the muscles of the face. So it is a little higher risk, but it can give sort of a higher reward in selected patients. So basically, a deep plane facelift is a type of facelift where the dissection is deeper, and the goal is to get more sort of better elevation and also potentially a longer lasting result in the long term.
You know, the other point of why to do a deep plane facelift is how things are mobilized in the face. So the main reason is there's a series of ligaments that are along the face in these regions. And the deep plane, if you're in a safe plane, you can easily release those ligaments so that you can get a better pull of the face in an upward fashion. And so that's the main reason to do it. But, you know, what I might also say is life is a game and you just have to play it.
You have to play it.
Sam, what do you perform a high volume of deep plane facelifts in your practice?
I never have done a deep plane in my practice. And I think the reason is that there has continued to be discussion and no consensus in our specialty in regards to which facelift is the best facelift. I don't think there are certain things that we have come to agree upon as surgeons about certain techniques, certain procedures being the most efficacious. And I don't think we've come to any agreement about which facelift technique is the best technique universally. There are people who advocate skin only, and they said there's nothing, and there's research to show that they'll point out to studies that there's no long-term benefit to doing anything other than a skin-only facelift. There are people who do SMAS facelifts or different variations of SMAS facelifts, SMASectomies, or extended SMAS facelifts where they go even farther medially. And then there are those who do deep plane. And so without a lack of consensus, my approach, and I also never trained, honestly, with someone who routinely did deep planes, which wouldn't necessarily stop me if that was the best way overall to do it. But everything I ever trained with was some sort of extended SMAS or SMASectomy or SMAS plication or some type of SMAS procedure. And the results I got from those procedures were great, especially when I added some fat to it and adjusted the vectors a little bit. I have watched videos and seen demos of deep plane facelifts, and it honestly scares me a little bit. I mean, I am not, when you don't know the surgical anatomy well, that's where the fear sets in. And as Pacella said, Sal said, everyone is different. And so when you're like sitting there tediously picking out all these little nerve branches and trying to figure out what goes what, like to me, that's not a place I necessarily want to be in for what our specialty has not universally proclaimed to be of long-term or overall benefit. That's my thinking on it.
You know, the technique is really not for the faint of heart. And I think, one of my mentors, Foed Nahai, is a prolific plastic surgeon in Atlanta. When I was a fellow there, I asked him, after how many years do you think you felt comfortable doing a facelift? And he said, how many years have I been in practice now? At that point, I think it was like 25. He's like, well, I haven't quite gotten there yet, And so it is an operation that when I see it on my schedule, I every single night before review the anatomy again. The morning of, I review the anatomy again as a refresher and map out in my mind exactly how I'm going to do it. And I would say that I rarely do that for any other operation. 16 years of practice. It is a high anxiety but a tremendously rewarding operation.
Yeah. I feel fortunate because of training at Manhattan Eye and Ear. I got to train with people who did high volumes of deep plane facelifts, where it's a technical nuance because I think people are using the term deep plane to involve any manipulation of the deep plane or the smash layer. But in a true deep plane facelift, the skin is phrased as a composite flap of skin and the deep plane. But I trained with people that did those. I trained with people that did extensive SMAS manipulation. I trained with people that did SMASectomies. But what it seemed as though were the most important things were, one, the experience of the surgeon. The guys that did a lot of facelifts consistently got great results. And there was one surgeon there in particular, Dan Baker, who did a prodigious volume of facelifts, who sort of revolutionized a more limited manipulation of the SMAS, either a SMAS plication or a SMASectomy. And his results are unbelievable. And the other thing that I think is the biggest advancement to facelift techniques in the last 20 years is the addition of volume. I've known all of these guys for 25 plus years, and thinking about how we all looked 25 years ago, the biggest difference in our faces is that we've lost a ton of facial volume. And, we keep revisiting the same manipulation, having the same arguments, the same manipulation about the SMAS layer. But ultimately, I think you need an individualized, tailored approach to every patient. And I don't know if you guys remember the twin studies that were done sort of in the mid 90s.
Yeah.
Where they're, because for the viewers, plastic surgery meetings are sort of this interesting clash of egos where you get, particularly in the world of facelift surgeons, where you get people that are champions of their own technique and they do it on everyone. And they had two sets of identical twin studies. I think it was like 1995. And on one, it was Sam Hamra, who was the proponent of the deep plane facelift. And on the other, it was Dan Baker on the other twin. And I think it was Owsley and Oscar Ramirez for the other ones. And they looked at the patients a year out, 6 years out, and 10 years out. And honestly, I think Dan Baker's patients look the best, but that's a matter of debate. So I don't know. I think ultimately people want to feel like they're getting the best plastic surgery procedure. And sometimes in this age of social media advertising, they are led to believe that in all cases, a deep plane facelift is the best.
Yeah, I think that's true. I sort of had an evolution throughout my career, because when I started, I started doing a procedure which was basically a SMAS flap. That's basically where we elevate the SMAS. So it's technically, you could call it some form of a deep plane. And, that procedure was not as nerve-wracking as, the current quote unquote deep plane is, but it was still a procedure where you went under the SMAS. That's where the nerves are. And if you went very medial, then you would start seeing the nerves. And I probably used that technique for the first 5 years of my career. Then actually, I did hear a lot about what Dan Baker was doing, and I started trying the SMASectomy and SMAS plication. And what I found was there actually was no difference in my results. And the reason why I eventually switched over to Dan Baker's technique was mostly because it was safer, it was less surgical time, and if there was no beneficial, no benefit in terms of result, why increase that risk? Now, later on in my career, I have done some limited deep plane facelifts, and I've sort of found the same thing. It's not really that much different. Maybe I need to do a lot more to see a difference, but I would agree with what Sam just said. It's probably surgeon dependent and not necessarily technique dependent.
I think when we talk about deep plane facelifts, the issue always is that, as Sal said, a lot of it is marketing. And people out there will say deep plane facelift, and we as surgeons really know what a true deep plane facelift is. It is nerve-wracking. It is anxiety-producing. It's a difficult procedure to do. And yet surgeons out there marketing will casually throw that out as a term when they are not doing anything close to a deep plane facelift, not even. And so I think what really matters when patients are looking for facelifts is you have to look at the surgeon's results, not what, quote, technique they're using, because that can be very misleading. And I think surgeons can take advantage of that lack of understanding of the anatomy and the type of technique to make it sound like what they're doing is better than somebody else, when it's really not even what they're advertising.
I just want to make a comment for the viewers. The reason why this procedure is potentially very nerve-wracking is because if a patient has the nerve injured, they're going to have potentially some degree of paralysis in the face, meaning your face is going to look crooked when you smile and when you speak. And generally, if it's a true injury, there's no way to fix that. So that's why all of us on the panel are, stressing that it is a challenging procedure and should not be taken lightly.
So when you do the procedure, how do you approach your dissection? Because I will tell you, and if I see a nerve branch, I'm freaking out. Like, I'm like, I really even shouldn't be this far.
Well, so, I do more of a kind of a bilaminar facelift, if you will, not in the sense of the hammer technique or the Jacono technique where they're lifting up a little bit of skin and then diving deep. I've found that procedure very confusing and very easy to get lost. And I don't like the fact that you can't manipulate the skin in a different vector than the muscle. So I lift up all the skin as far as I can go, release these ligaments down here. I think this is a key component to release these ligaments subcutaneously right at the mandible. That's what gets rid of these jowls. And then I start the deep plane basically at the level of the platysma. Because to me, the platysma is pretty thick. It's very easy to identify. And it's probably the safest place to start because you know where the marginal mandibular branch is going to be. As long as you stay underneath the muscle, you can get at it. So once I've elevated and now I also have done this dissection first. And so I've connected these two planes. So I can see the platysma from here and I can see the platysma from here. Okay. So then once I've elevated the platysma, I then transition that into the midface. To me, this is the most challenging part to do right here, right? As you elevate this up, I'm watching for the parotid gland. I'm seeing if there are any nerve fibers coming out of the parotid gland. I know I want to stay above that. What's exceptionally confusing is determining the difference between nerves and ligaments. Okay. And so those two look almost identical. And what you think you're cutting a nerve, you're actually, what you think you're cutting a ligament, you could be cutting a nerve and vice versa. Right. So there's a lot of sort of discontinuous stretching and undermining that I do to kind of elevate that area. And that's kind of how I approach this dissection. So like at this point of the dissection, I'm focused as tightly as I can, going systematically, exceptionally slow. And so that's kind of the main way I approach.
So you're doing more of an extended SMAS technique than a true deep plane.
Composite deep plane.
Yeah.
Right. But technically speaking, it is still a deep plane facelift because it's the same extent of dissection. It's just whether or not you elevate the skin, right?
Absolutely. No. And I definitely do a decent number of those as well. I think Pacella's explanation is almost exactly the same way I do it. I tend to inject a lot of local into the SMAS when I'm doing it as well. That makes the dissection a little bit easier. But it is incredibly nerve-wracking. And, if you do see a facial nerve injury in your patient post-operatively, pretty good that it's going to resolve, but those many weeks or months while you're dealing with it is nerve-wracking because your patients all look like they've had a stroke, which is not the desired outcome after a facelift, obviously.
So for the listeners out there, there's this, I maybe these guys will share this feeling. So, doing an extended SMAS, deep plane facelift, brow, bleph, all in one, this is anywhere from a 5 to 8 hour operation many times, right? So when you're done with the operation, you feel a tremendous sense of relief because, your body has been like this the entire time. Okay. Like looking underneath the skin. All right. And then that elation and celebratory feeling is directly squashed once you go to recovery and your patient is waking up. And the first thing you do is you're like, hey, can you smile for me? Show me your teeth.
Yeah.
Raise your eyebrows. Okay. That's like, until I can do that, I won't sleep the rest of the week.
I don't do that till post op number 1.
I don't do that
either. Like you do that right after. There's still all that local in there.
But I take the chance because sometimes the local has gone away and sometimes I see it. So I agree. If it's only beneficial if it's positive, meaning I can see the movement. If they're not, I by the next day I'm sort of absolutely looking for it. And I have them come first thing in the morning, the next morning, so that I can see them.
Yeah, I usually just expect that their face is not going to move symmetrically right after, like if you're checking them post-op. So if you're going with that attitude, then it's you won't have to lose any sleep. But
Sal's the kind of person who tends to open up the presents right away as opposed to waiting until Christmas morning. He wants to check early.
So from a plastic surgeon standpoint, we all agree that doing a deep plane manipulation, whether it's a true composite deep plane lift or an extended SMAS, is certainly more nerve-wracking. But do you guys believe that the incidence of nerve injury in an experienced surgeon's hand is greater with a deep plane manipulation versus more superficial techniques?
100%. Yes. I mean, this anatomically makes sense, right? I mean, even if the nerves are stretched, or irritated a bit. So yes, I would say that's true. It may still be very low, exceptionally low, but absolutely higher, no question.
So then what do you make of all these surgeons who claim they've had no nerve injuries yet do hundreds or thousands of these procedures?
Yeah, I think that's some aggressive marketing.
That's a nice way of putting it.
Yeah.
I think it's possible, but I totally agree with Sal. If you're going into the plane where the nerves are versus you're operating in a plane where the nerves aren't located, you're going to get more risk of injury to the nerve when you're in that plane. There's a saying in plastic surgery circles is if you're not getting complications, you're not operating enough. And so even if you are very experienced, you are going to get an injury at some point. And for the claims of never having had an injury, it might be never having had a permanent injury. I mean, temporary injuries aren't that unusual. And we've just said, by definition, if you see somebody whose face doesn't really move for the first couple of weeks and then it comes back, that's a temporary injury. So I think that, it is a bit of marketing if somebody claims that they've never had a nerve injury.
What do you think, Sam? Oh, sorry, Sal.
No, I agree. I don't think anyone who does true deep. I mean, I don't remember what Sam Hamra's complication rate was with that in terms of permanent nerve injury. But I think what's really telling is what you said. Like, there have not been any studies that have shown that that type of technique is definitively better. And so, if anyone who says that is out there, they're lying. That's not what the research and the literature supports. And but ultimately, it is the experience of the surgeon that determines the outcome and success more than anything else. And for any procedure, especially the more technically involved procedures, it's always surgical experience. It's not the technique or what they specifically do or do not do. It's really about that individual and what their experience and skill represents.
So, the true facelift, whether or not you're lifting up near, far, wherever you are.
Wherever you are.
Oh my God.
True that your
Why
heart
is-
will go on.
Odd Celine Dion reference, but okay. Well, the reason, getting back to where we were, the reason I asked that question was there was a big meta-analysis published last year or the year before where two people we've had on this podcast, Dr. Rorick and Dr. Avasio, were the last and first author on it. And when they looked at the meta-analysis, all this self-reported data amongst, because again, published data is from surgeons themselves. They're publishing their own data. We're not looking at each other's stuff. The published rates of nerve injury are actually basically the same between more superficial and more deep manipulation. But I don't think any surgeon believes that, including those of us that do deep plane manipulation. So I thought that was interesting. And yes, what Sam said was true as well, that there is no published data or long-term study. And when there's been a couple of twin studies that are out there that really definitively shows that one technique is better. So I think we're all coming to the same conclusion that Pacella said early on in the show, that you have to take an individualized approach to the patient. Do you guys do the same technique on every patient? Any of you?
No, absolutely not.
Well,
And then,
I would say the generalized approach is the same, meaning the incisions are relatively the same design. The elevation of the SMAS, the way I started, is relatively the same. It's just the extent of the vector, where you're pulling, where you want additional volume, where you're putting the fat, how aggressive you're going to be, what sutures you use. That's all kind of tailored based on what we find in the operating.
yeah,
Agreed.
I totally agree with that. And I think, we've all changed things in terms of how we do things over the years. We all have discovered techniques that we like more as we get more experience. But ultimately, I think we all, have developed a technique that we feel pretty comfortable is durable, provides durable results for our patients. So I feel like we've exhausted this topic, unless you guys have any more you want to add.
Very nice.
Nope.
Yeah.
All right.
I think
Well, then, with that-
I'll have one comment. For patients out there, you got to look at, we talked a lot about marketing. Sometimes you will see a lot of marketing where if you actually look at the patient who's having the surgery, they're not really that old looking. And so if you start off with a patient who's fairly young looking to start off with, they're going to look really, really good no matter what technique you use. So just keep that in mind. Like, see if you see examples where the skin is very saggy, if everything is very lax, because if you're starting off with a patient who's like in their late 40s or early 50s doing these surgeries, they're always going to look good no matter what technique you use. And that's part of the marketing that goes out there.
Very true.
Okay. Well, gentlemen, it was a pleasure as always. And until we meet again, take care.
Take care.